Good evening and warm greetings to everyone joining us from Bangladesh and around the world. I am MD Jubair Islam, serving as a medical physicist and radiation control officer at Labit Cancer Hospital and Super Specialty Center, Dhaka. Currently, the Secretary General of the Bangladesh Medical Physics Society, BMPS. It is my great pleasure to host and moderate the today's special webinar organized by BMPS to celebrate the International Day of Medical Physics IDMP 2025. This year, global theme Medical Physics and Emerging Technologies Shaping the Next Decades highlight the crucial role of medical physicists harnessing innovation and technology to advance healthcare. As part of this celebration, today's session focused on timely and transformative topics, AI-guided radiotherapy. To begin our session, I would like to warmly welcome Dr. M.D. Akhtaruzzama, President of Bangladesh Medical Physics Society and Chief Medical Physicist, Evercare Hospital, Chattogram, to deliver his welcome remarks on the occasion of IDMP 2025. Dr. Akhtaruzzama, the floor is yours.
Thank you for the nice introduction. Ladies and gentlemen, very good evening from Bangladesh Medical Physics Society. So on behalf of the Bangladesh Medical Physics Society, I am Dr. Mohammad Akhtaruzzama, President of BMPS, and it is my great pleasure to welcome you all to the today's webinar on the auspicious occasion of the International Day of Medical Physics IDMP 2025. Since the announcement of IDMP by the International Organization for Medical Physics, IOMP, BMPS has been celebrating this auspicious day every year by organizing seminars, webinars, and publishing our electronic newsletter, The Voice of BMPS. As part of this continuing tradition, we are delighted to host this year's webinar on AI-guided radiation therapy, which will be presented by the Professor Xiance. He is a Chief Medical Physicist at the University of Wenzhou, China, and the Vice President of Asia Oceania Federation of Organization for Medical Physics, AFOM. This session will be moderated by Mr. Muhammad Jubairul Islam. He is a medical physicist at Labit Cancer Hospital and the Secretary of Bangladesh Medical Physics Society. So without further delay, I would like to invite Mr. Muhammad Jubairul Islam to conduct this session and wish you all the happy International Day of Medical Physics 2025. Thank you.
Thank you very much, sir, for your inspiring words and continued leadership in advancing medical physics in Bangladesh. Now it is my distinct honor to introduce today's distinguished speaker, Dr. Xiance. Dr. Xiance served as a Chief Medical Physicist and Vice Dean of School of Basic Medical Science and Vice President of First Affiliated Hospital, Wenzhou Medical University, China. He is also serving as a Vice President of Asia Oceania Federation of Organization for Medical Physics, AFOM. He is also Council Member of International Organization for Medical Physics, IOMP. He is now Vice Chair of Radiotherapy Physics Group of Radiation Oncology Committee of Chinese Medical Association. He is also served as a Chairman of Jianjing Anti-Cancer Association of Radiation Physics Technology Group. Before the talk, I would like to attention to all our participants. Please keep your microphone muted during these presentations. You may post your question in the chat box anytime. We will have a short question and answer session after the talk. Now, without further delay, let's warmly welcome to Dr. Xiance to deliver his presentation on AI-guided radiotherapy. Dr. Xiance, the virtual floor is yours.
Thank you. Thank you very much for the introduction. And also, Thank you, Professor Akhtar, for the invitation and the arrangement for this. I think it's very wonderful ceremony for our International Day of Medical Physics. So now I'm going to share my screen. So I think it's really great honor to share with you tonight in this special day for something about AI-guided radiotherapy. But as the beginning, this is our holiday, actually. It's the 2025 International Day of Medical Physics. I think this has been 13th celebration day for our international. We all know that medical physicists actually make our medicine much safer, smarter, and more precise. So I would like also to use this opportunity to extend our gratitude to all the medical physics around the world, around in the African regions. Thank you for your making the medicine safer, smarter, and more precise. And also wish you enjoy today. So that's our day. Before the beginning, I would like to give you a brief idea about where I come from. So, the Wenzhou Medical University, first affiliated hospital, we actually it's a hospital with 106 years old histories. We established in 1991. Actually, this is the first hospital established by Chinese people in Wenzhou City. Previous hospital was especially run by missionaries at that time. So currently, we have three campuses. You can see we have over 4,000 beds, and the last year we have patient visitor reached to 6.3 million. So with an employee over, I think it's 7,000 now. So it's very, very large hospital, and in the medical center in the south part of Zhejiang province. So this is brief. Also in our hospital, we are highly evaluated education. We also in the first college of Wenzhou Medical University, we actually take in charge of the training for the course for the undergraduate students for the medical majors. We also have master and PhD students, over 1,500 master students, over 3,000 undergraduate students. Also, there are some students in training. It's about over 1,200 students. So actually, our hospital or the college is all around a multi-level talent training system for undergraduate, master, doctor, and postdoctoral education, or international students too. In my team now, I have two PhD students from Bangladesh. No, it's from Pakistan. So every year I can enroll, like say, include three master students and the one PhD students from outside of China. So if you have the medical physics, fellow medical physics in African region, if you are pursuing a higher degree, you can contact me for training study in China in Wenzhou Medical University. Wenzhou Medical University, especially our first affiliate hospital, is very famous, or we are good at it, to construct a smart hospital. We build our own systems like electromedical report systems, all the necessary running systems for the hospital running. We have self-developed over 100 systems, obtained over 200 patents in software patents. So how we achieve this, I can give you some examples, like say, in this AI booster area, we have built an agent or large language models for pre-hospital consultation. As we know, the patients always have confused when they first visit the hospital. If they are symptom like they have fever, it's hard for patient to decide, to know which department they should visit, what kind of doctor they should go to consult. So we build this large language model after 3 to 5 round of chat, just like you use the WeChat or WhatsApp chat, the system will tell exactly which department they should go to, and we can make a point directly for these patients. And we have run this system for over 1.5 years, and the results, the uh, prediction results, or the appointment results is the accuracy is reached over 95% accuracy. So it's very amazing now. So lots of patients use these AI-based consultation systems. When the patients in their appointment day, they came to our hospital. So as long as they approach the gate of the hospital, we have like over 60 cameras around the hospital. The hospital will detect the patient's face, and our system will directly, you know, register, check in for these patients. So the patients can have guidelines. So check it. We already automatically check in for these patients. So, and we will send the message to the patient to their cell phone, tell him or her where to go and at what time exactly, how many minutes into minutes, like say 10 to 10. So you can go to room, clinical room, or which room, so you can see the doctors. So this is our guided visiting systems. But in the consultation room for the physician too, we have some amazing tools for the physician. They can generate the electron, the medical report automatically. They don't need to type the computer anymore. So we have microbes. The AI tools can generate the medical records for the patients, for the physicians. Also, we have lots of AI assisted analysis tools like imaging tools. Also, we have built integrated the DeepSeek, the large language model in China, very famous, into our medical record systems. So they can help the physicians do all the light jobs during the consultation room. Also, we try to provide one visit for all the patients. That means when the patients come to the hospital, they don't need to come to. We try to finish all the exams or math things or all the things on one day. So especially for MR, CT scans, our staff will help the physician to finish all the scans in exams in one day. So they don't need to come tomorrow for additional tests. So by this way we overdue. So the our staff was work hard until I think late night every day. So but that's benefit of our patients. Also, when the patients leave the hospitals, we still continue our services by sending the messages. We have checklist for them, and we can have some call them, remember what time they need to take medicine, what time they should come back to for revisit to reconsult the patients, the physicians. So we have after hospital service too. The basic idea is we try to use in this AI era, we try to build a new hospital, like digitalized hospital, or we call future hospital connectivity. So in the future, we have really different way for healthcare management for the patients, for the physicians, for the staff, for the administrations too. So we try to build all based on AI. We can boost the connection with physicians and provide convenient services for all the patients. So that's the basic idea behind. So for today's topic, actually, for the AI-guided radiotherapy, the basic idea is, we are in a new era. Everybody should realize this, right? We are in the fourth industrial revolution. So the medical informatization and intelligence are inevitable. It's always there. It will eventually develop to that certain stage. So everybody should use AI. So in this situation, we need to deal with how to cope with the new round of technological or industrial revolutionization. Everyone should learn how to deal with it, how to cope with the AI systems. So the whole society need to achieve a development for the new industrial, like industry 0.4, they say, right? So we use machine learning, deep learnings. As far as for AI, for science, actually it already there. And lots of science and the technologies was based on AI, all developed for AI. For really two famous examples, everyone knows, do you realize last year, the Nobel Prize in physics for 2024? This was actually awarded to some computers, right? Computer researchers, they are trained artificial neural network using physics. So that's the AI for physics. Similarly, for AI, for the Nobel Prize in chemistry in 2024 is also was honored for the people who use the AI to predict the protons structures. So the protons emitting structure was very difficult. They solved a 50-year-old problems. So based on these predictions, we can fasten our medicine development. So that's why we for the radiotherapy again, we in this area, how can we incorporate our AI into our radiotherapy systems? We know that radiotherapy is kind of complex. And we have several steps involved, several steps. Like we need to first we get an image, then the physicians need to draw the targets and the OARs. So our medical physics planning, or no, someone is in different countries they have planning technicians. So we need to do the QA, quality assurance, monitoring, and the motion management. Also, we try to with the physicians, we need to predict how the prognostic goes with the radiotherapy or the comprehensive treatment, right? So we can actually AI can be involved in every step of these procedures. So like the first step, the segmentation. We know segmentation is really a task. It's time-consuming task. It takes a lot of time for our physicians. So at first, we have a system called knowledge-based, atlas-based automated segmentation. Do you know, guys? I don't know you remember it. It means like say we collect all the contours from some good examples. We connect the contours aside. So when the new patients come, we just try to pick some of the contour that are similar to these new patients from the atlas. So that's called atlas-based automated segmentation. So it saves some time, but it's not as precise as we now, because when the software, the algorithm developed, the deep learning comes, like the convolution neural networks come into practice. So people use the deep learning to training some models to automatically draw the contours for the patients. So now we are basically lots of work are done for the deep learning based auto segmentation. This is some work we did too. But as for the deep learning based system, one key problem, key step of the deep learning is the ground truth. So all the deep learning algorithms, they build the models based on some ground truth. But as medical physics of the radiotherapy, we know that the contours actually is very difficult because different physicians, for the same patient, they can draw kind of different. Even for the same physician, they draw the contours like today, it kind of be different from tomorrow. So that means the ground truth for deep learning models for auto segmentation is kind of rare, right? It's not exactly the same. So we are trying to figure out, is there are objective contours that can help the deep learning system to do the auto segmentation? So we think that we kind of figure out like the radiomics, if we can draw the contours by some object radiomic features. The radiomic features can help us draw some contours, GTVs or CTVs from the images. Does this more objective than the physician's physician's results? So we try to figure out if radiomics can guide us to more precise auto-segmentation systems. So that's one of what we did for nasopharyngeal cancer patients. Just use CT, but we use we actually around the GTVs, we extract some radiomic features so we can try to help figure out how exactly which the objective contour lines for the GTVs. So this is our training. So actually, automatic segmentation is very useful for radiomic study itself too. So we did a lot of auto segmentation with ultrasound, with CT, with MRI for different cancers like cervical cancer, nasopharyngeal cancer, and so on. So this is the first part of the automated segmentation with AI. So as auto planning is same. So treatment planning, design is kind of also with very hard tasks. It takes a physician, a medical physicist, I think 1 or 2 days sometimes. Yeah, even sometimes it takes us 1 week to finish one very hard cases. So when the AI come, can we use the AI to do the automatic planning? So at the first thing we call this the auto planning system. We call it the knowledge based automatic planning. That means we we extract some information from DVH, those modern histograms. So from the plannings, so we extract these features aside. So when the new patients come, we just try to match the geometry of the new patient to the old patients. So we can copy the DVH directly from the old patients, and then we can make some change for the new patients. This is called knowledge-based auto segmentation. But when the deep learning come, we try to use the deep learning system to try to build some models for automatic planning. That's the second part, actually the second stage. So stages when currently actually the planning is kind of different from the planning we are delivering. What we need in clinic is the planning that can be directly delivered by our machines, our LINAC. It's not just that you have predict some dose distributions with auto plannings. So currently, lots of work focus on so can we predict direct some plannings, some dose distribution that can be delivered directed by MLC. So this is currently the development of auto segmentation. Yes, the stable for the quality assurance, that's the main task of our medical physics thing. But the problem for the QA is, in some very busy centers like us, we have I think we have around 400 patients per day. So the QA basically we need our medical physicists do the QA most of the time was after the work hour, like late night or weekends. So Saturday and Sunday is most of the time that our medical physicists need to do a lot of the QA works. So when the AI come, can we try to use some AI system to help us to do the auto quality assurance? So previously we did a lot. You can see we did a lot of QA studies. But at this point, when the AI comes, we can use machine learning or deep learning. We can extract some parameters from our plans, like complexity of our plans or something like this, to connect them with gamma passing rate. So when we do the QA, we get the gamma passing rates. So by this way, we build a model. So when the new patients come, we can extract some of the parameters from the plane, so the plane can be directed to predict how this plane can pass the gamma passing rates. So this is example. Another example we did. We actually integrate the plane complexity and with the dosimetrics features. Dosimetrics features means we use the dose distribution as the figure, as a figure. Then we use radiomics skills to extract some features from this dose distribution with images. So we use integrating plane complexity and the dosimetrics features, and then we use the deep learning for QA for we met patients. That's we how did, and we achieved. I think we showed results. Accuracy around 85%. I think. Yeah, that's good. So, but the one problem is like say all these automatic QA was connected with our gamma passing rates. So it's gamma passing rates. But the problem is so many study find out that the gamma passing rates it's not sensitive enough. That means when the study shows that even we actually introduce some errors during the QA procedure, but the gamma passing rate is still like say over 90% or 95%. Even we have some mismatch between with the plane we are doing QA and the plane we measured. So that means these two are totally wrong. It's mismatched. But the QA, the game passing rate does still tell us the game passing rate is about 90% for 2%. So like this. So many people say that we could not like say rely on game passing rate for the IMRT QA only. We need to actually focus on the DVH. When we finish the QA, we should reconstruct the measurement results into our previous the primary CT image to reconstruct the measure the plane, so those distribution. Then we compared with our planes with DVH curves with some metrics for extract from DVH. So that's called DVH-based QA system. QA. However, the problem is if we did this way, QA in this way by analyzing the DVH errors, that means it makes our QA procedure much more complicated, right? We need to we go back to planning again. We need to evaluate the DVH slice by slice, so it takes increase our work volumes. So our team is all thinking if we need to use the DVH based QA for our MRT or MID, but in this new era with these AI tools, can we develop some new systems for the DVH based QA so we can improve the efficiency and also increase the QA accuracy? So that's how we designed. I think it was 5 years ago or 6 or 7 years ago. So we try to use QA AI to help us to build a DVH based automatic QA. Like we separate into two steps. The first step is we use dose deep learning to predict the dose distribution of the measured results, the QA results. Right? When we did the QA, we have measurements with phantoms. Then we reconstruct those distributions in the primary cities. So we skip this step. We just use deep learning to predict the measured result directly from the deep learning system. So on the primary city. So by this way, we have a second set of DVH and those distributions. So with this predict those distribution, we can compare it with our plane ones, the primary planes one from the TPS. So by this comparison, so we go to the second step. What do? We need to figure out based on evaluation the DVH distributions. Like we maybe have 20 or 30 metrics from DVH. How can we like say judge if this the measured one is matched to the primary one or they have deviations? How can they tell it's this plane passed the QA results or not? So we use machine learning tools like we have different set of combinations like those arrows and the rolling arrows, or even we have actually generated some new ideas we call individual gamma passing rates or global passing gamma passing rates. So we have different combinations of these metrics to decide is this matrix fail or pass. So we just figure out a math to classify the measured one based on DVH distribution. Is this QA passed or not? So our test, the primary test that shows we test on 28 head neck patients with IMRT. I think we met. So and compared with the results judged by our senior medical physicist personnel. So the results actually was matched to the accuracy we can say is 89%. So it's pretty good results. So we keep on first thinking is like when we use DVH based QA, as we do the planning, we do the treatment planning, we actually have different weights when we do the planning. For different OARs or TPS, their DVH actually have different weights, right? We will highly weight the DVH, the metric for the PTV. So we will try to make the control of the tumor. So the DVH or say 95% of volume will covered by 95 prescription dose, ice dose. So we will highly value these metrics. And some other metrics like the OARs, they maybe have low weights, right? So we have different weights for different metrics, DVH metrics. And this new, like, is there any AI tools can help us, or we can build a system, an algorithm, help us to sort out all these DVH scores, DVH weights. Like we just try to training a algorithm, like tell us we have different metrics score weights, so we can finally this is the algorithm, the we call the equations we build. Like so we have a different weight metrics, different weights. So we but try to tell us, like say, for one patient, they should have one final weights score, DVH score. We should try this way. We build a DVH score for the QM results. So this is the way how we calculate with the deep learning and the machine learning together with. So finally, we like say we build for all the patients for the a group of patients, we will find a limit of score. Like say for these patients, their score should reach 49.62. If the patient score was higher than this limit score, then it means the DVH based QA was passed. If lower than this score, that means the patient we need to rethink. We need to go back to check the plan again. So for different group of patients, we can calculate different scores for this one for the patient. So by this way means we go back to one gamma passing rates, but this time we are actually was based on the DVH based QA system. So that's how we achieved like DVH based QA system for one DVH score, and that's improve our efficiency for QA IMRT QA. And we just get this published in this year 2025. So our score actually the score classification achieved precision of 95% and the 88 about 88% in two test groups. It's quite amazing, right? So we also earned some patents for these two algorithm, like say dose-wall histogram based retreatment the patient specific Q assurance. Yeah, with this we also have some transformation for this system. We also build a system to test to collect for the public use to platform. So people, if you you can test on this system with your own IMRT women cases to see how your cases works. I think it's some problem with our okay. So this is our medical physics part with QA and planning and auto segmentation. But for any treatment, for radiotherapy, for chemotherapy, the final goal to achieve tumor control to increase the patient's quality of life. So I mean the prognostic prediction for patients is more important than basically the physical exams. So by this way, we try to use the radiomics for radiotherapy. Can we use radiomics to predict the outcomes? They can predict the prognosis of these patients when they underwent the radiotherapy. Yeah, that's the work. So the first is like say the prediction of the staging for the esophageal cancer. We use PET-CT. The stage for esophageal cancer is kind of complicated, but the stage is very important for the decide for these patients, right? So the patients like say, I'm sorry, there's some problems. So when the patients like say the treatment of the patient were based on the stage, but the stage we can only get the stage information after some surgery. So after surgery we can get some information, the lymph nodes number, the lymph nodes metastasis, so we can go back to like say what the stage of these patients. But at that time, the treatment was limited because he already did the surgery. So what we're thinking is, can we predict early before, like pre-operative prediction for this esophageal cancer, so can help the physician to decide to choose an optimal treatment modality for these patients. So we use PET-CT, try to predict the clinical and pathologic stages for these patients early. So that's the work. And then we did cut 2 years ago. And another is, the esophageal cancer is kind of popular in China, but the radiotherapy and the chemoradiotherapy actually was one of the major treatment modality for the esophageal cancer for the advanced case. I think nearly 70 to 80% of the esophageal cancer patients was diagnosed at advanced stage. So they only have used the chemoradiotherapy, but the problem is nearly 50% of the patients were recurrent. So we will recur like say the recurrency after the treatment. So we try to think: is there any way we can find out which patients will not respond really good to the radiotherapy, or to is not respond good to well for the chemoradiotherapy? So we use radiomics. We use combined with radiomics with CT with dosimetry. That means the V20 or the magic the dosimetric metrics from the DVHs. So this is the job done. I think it was 6 years ago. So currently we use the dosimetrics with CT. So for the dose response, I will discuss later. Also, during the radiotherapy, radiation pneumonitis is kind of very a major complex. It's major side effects for the patients. So, but we don't know why. So it's sometimes weird. Some patients it's easy to get RP radiation pneumonia, but some don't. So we try to figure out which patients, which group of patients they're easy get the RP. So we use the radiomics, kind of different meals for the esophageal. This is for the esophageal cancer. We also did for the lung cancer with multi-omics with deep learning. So I don't want to go to detail about this method. So if you like, you can search these papers. We can discuss later about how we do this. How can we use the radiomics method to do this? And this is for this I think this was popular in this month, and we just get this published in this month for PET-CT radiomics for radiation pneumonitis for the lung cancer. Yeah, the thing I won't go to detail. I think the results it kind of close to 90% accuracy for all these studies, and this is for the radiation. It's called esophagitis for esophageal cancer. We combine different models: deep learning, dosimetrics, also clinical factors. We say you can see combined deep learning and radiomics for pre-treatment radiation esophageal prediction. And I think I was we go further. This study I actually reported in the AFOM annual meeting this year in Australia at Adelaide. So this study tried we figure out that we can predict the esophagitis, but we know for the radiomics, as the region, the ROI, the region of interest you work on, you extract the features from, it's kind of really important for the results. So can we just say, can we find the really optimum one? Because sometimes we draw the ROIs, different students, different medical physicians, different physicians draw different ROIs. We just try to ask the AI to help us, deep learning, DeepSeek to help us to find the optimal ROIs regions for us to do this radiomic study. So we use called the multi-branch fusion actionary learning to try to help us find a optimal region for the study. So, and this was also published in our Green Journal in this year, 2025. Yeah, this is another study we finished this year. Is because now it's immunotherapy is very popular now. Actually, immunotherapy have this improve our efficiency of radiotherapy when combined with radiotherapy. But immunotherapy, the immune system, the function of patient immune system is very important for the immunotherapy. But lots of patients, when they undergoing radiotherapy, actually they suffering uh, uh, they call the lymphonia. So there are lots of grade 4 radiation induced lymphophonia. So can we predict which patients would like to suffer from this lymphopenia? So we use deep learning radiomics to predict this this R4 grade 4 radiation induced lymphophonia. Yeah, this is survival, but this time we use dosimetrics, say we say response, but we go further. Like we use the radiomics with the CT image, as we mentioned before. Like we use different to predict the disease-free survival and over survival for the esophageal cancers patients. So the previous study was focused on esophageal cancer mostly. We also did a lot of radiomics study for the cervical cancer. It's used the ultrasound images because cervical cancer is also the radiotherapy involves much in the treatment of the cervical cancer. We have a good clinical cases, especially we have a clinical trial. Our physician, they won a best or astral in I think it was 2018 or sometime. So they have a good clinical trial and with good clinical cases. So we are thinking, can we help them, like use radiomics to help them to do some predictions to help them to increase the clinical efficiency or some treatment outcomes. So we use ultrasound. Ultrasound is the first step to diagnose the cervical cancers. So there's a lot of ultrasound images. But we did a survey actually, and we did a review study in 2020. So at that time, we find there's lots of radiomics for cervical cancer, but actually none study was use ultrasound. So we found we figure out that ultrasound maybe is good image for us to study the radiomics for the cervical cancers. So we did a lot of from then on we use ultrasound image to predict the I think it was for the lymph node status, their radiation, proctitis, also with MR as well. So, but the one problem is, ultrasound. There in one hospital there are lots of different ultrasound machines. In my hospital, we find that there's over 20 types of machines. Different machines produce different image quality of images. So some is good, some is bad. So we are just thinking. We actually studied the effect or influence of these ultrasound machines, the effect of the auto segmentation masses algorithms on the results. So affect the radiomics. So we try to figure out, is there any way we can increase the image quality by, like, say, staff transfer? Like we pick one machine with the highest quality of ultrasound images. So we we can just convert all other machines, the image from all other machines to this machine. So in this way, we will increase the consistency of the image quality. So by this way, we try to improve the radiometry results. And this result was actually was accepted as oral presentation for AAPM 2023. And I think we get this, we published, oh, I didn't update it. We actually published in this year for these results. This is for the recurrence prediction for the cervical cancer with MRI. It was, yeah, I won't go detail, but it was published in Green Journal, I think, in last year, 2024. Yeah, we also did lots of other radiomic studies like brain brain metastasis, and also some gastric cancers, thyroid, ovarian cancers. So actually, if you can do the machine learning, deep learning. So when you grasp the techniques for all these deep learning tools, it's kind of easy. As long as you get data, you can do results, you can cooperate with the physicians from different departments to do the radiomic study for them and work with them, and it's kind of easy. So over the past 5 years, I think we get around 50 papers published for radiomics. So I hope someone in front of the computer we can have cooperation in the future on this field. So yeah, we currently we try to build radiomic systems, platforms to generalize the image quality, to improve the image qualities. So we try to, yeah, this is multimodality platforms for radiomic study for the diagnosis, response, and the radiation pneumonitis and outcome predictions. This is we have done this platform and we will publish it soon. We actually start from this year. I think it was 2 years ago when the large language model come. The whole world is changing, right? Our life is changing, especially the DeepSeek in China published. All we are all chasing the DeepSeek, using DeepSeek for everything. So in this case, can we use DeepSeek for our radiotherapy? Yeah, that's what we are thinking now, right? DeepSeek is kind of amazing, it's a large language. So I think sure, DeepSeek can be applied in medicine and healthcare. It can combine with DeepSeek for automatic clinical documentation, clinical decision support. Also, I think lots of things. So I say that as we said we use DeepSeek, we use large language model for consultation for society. So there's one idea people should remember. You should get clear. The DeepSeek or ChatGPT, this we call for the general purpose large language model. So if we try to use this large language model for medical, we actually need to fine tune. We need to tune this large language for medical use it specifically. So we need to do some additional work. Not only it's not that easy. You can just integrate the DeepSeek or ChatGPT into our medical system. Then will tell us exactly how we know. There's some there are fake results when you use the general purpose language for medical purpose. So we need to fine tune. That's a hard job actually. So currently we are trying to build a large language model for latest Asian oncology. We call on-call large language model based on these pre-trained AI models. So we will input our tumor data set and the multi-stage instruction, fine-tune this and the reinforcement learning. So we need a lot of additional work to build these radiation-based large language models, especially. So, but if we can achieve this, it's really help us. If we would like to try to, we are actually building a new paradigm of efficiency, precise, and collaborative and patient-centered intelligent disease system. So we can, in the actual experience, we can, the step or procedure, we can do the QA at every stage and real-time QA. We can build our radiotherapy knowledge to help to training our young physicians, young medical physicians. It can help some decision support. It will be easy for us to date interoperability and resource sharing. It can enhance the patient's experience. But we just start this work. I think it needs half a year to 1 year and 12 months. We will publish these models. I hope at that time we have chance to share with you again. So they are also called this year start as AI agent, the year for AI agent. So we need to actually for this special area, this new AI area, we need to new technology into integrate this new technology into our healthcare. We must familiar with or we are used to the multimodal diagnostic treatment. We'll focus on personalized medicine, real-time dynamic learning. Right? We need to build a new ecosystem for our medical large language models, for medical data sharing, for medical AI agents. So this is our final. So in this area, artificial intelligence, AI is everywhere. No one can escape. No one can keep away from AI. So for our medical physicists, for the students, for the physicians too, we actually hug AI to integrate with our basic medical science research, clinical practice. So this is the way how we cope with AI to achieve a win-win situation in this new area. So that's my short change. Thank you very much for listening. Thank you.
Thank you very much, Dr. Jean, for your excellent and thought-provoking presentation. It was truly insight to learn about how AI is transformation in radiotherapy and enhancing precision in cancer care. We'll now move on our question and answer session. Already we have received several questions. Just I'm sharing PPT. We received in first question, what is the easiest procedure to feed data to AI?
Oh no,
6
that's no
minutes.
easy way actually. I think for the AI, the first step is the data. The problem is not all the data in the clinical it's useful for AI. Actually, it's the first really task, you know, hard task. You need to actually to clean the data for the AI for different models for different purpose. You need to like markers. You can we have some there's no easy way. You need to learn how to because for different purpose the model you need to deal with different with the AIs the datas.
Sure. We have another questions.
Our medical physics is also good at AI machine in any particular purpose course. I know. Oh, yeah, it's hard. I think I don't know because lots of the background actually we have a much more advantage than physicians in this part. Lots of I think most of our medical physics with the background with physics or some mathematics. So this actually really is critical part to learn AI, but so it's much easier for us to grasp some AI knowledge. So course I think there's lots of courses there online. We in our university actually we are providing AI courses for the very beginning for the fresh year. We call it for the medical students too. We ask them to take some AI, general AI knowledge courses. Everyone should take this. Yeah, that's the answer. So I will go down. So how can AI can affect the physical? Yeah, it certainly affect. It's not only affect your physics. Actually, in China now, AI is affecting every part of our life, not just medical physics. Your life, your study, your working, your because it's. I don't know how in your country in city, AI is getting involved in every step of our life. We need to use to it. We need to learn to deal with. I think that's the trend. No one can stop the trend. AI is the trend. No one can stop it. I think I'm not sure if there any red AI model predict outcome or there are some. I think currently I'm not sure. We need to search for this. Is there any agents companies start selling? But lots of study is going on. Lots of research was published on this part. You think no? Uh, it would be for the question 5. It would be dangerous for us if we escape the measurement-based QA. I think the current state, we will use AI as a tool, as a helper tool, help us to efficiently. We don't need to do the measurement QA for every patient. So, but I think we still need some measurement data to assure that AI is right. AI, you know, like large language model. Sometimes large language model is wrong. They can give you some fake results. AI too sometimes go wrong. We don't know where it goes wrong. Why? Uh, Actually, there are lots of studies. Because gamma passing rate, why? Because the equation is the only like say the equation to build the gamma passing rate is only point dose. So it like all the we call the spatial information of the of our planning system. So it's hard to for gamma passing rate as sensitive enough for the whole IMRT-QS. So that's my answer. With the last one, anyone online model pipeline we can do. Yeah, I think there's lots of company that's it's very I think it's mature now for the automatic segmentation. In China, we have lots of companies. They provide products that's really which is really amazing. It's physician or they only did only very small adjustments. So this saves lots of time for physicians for our clinicals. AI is not for simulation, but it can. Now you know the called the image generalization. You know now during the adaptive therapy, you use the CBCT or MR image during the treatment during the being delivery. When you collect the image or MR image, we can use this generate the CT image directly for planning chain like this. Okay, I hope I answer all the questions and I hope you are all happy. But I think it's a bit like short of time today. We can keep on offline when communicate with me. I'm open for any questions.
So
Thank you.
regarding the last question, Jin, I just want to make a comment on that. Actually, there are some tools, AI-based tools. It's called simulation-free radiation therapy. So the team from University of Western Australia, the Medical Physics Research Group, they have developed an AI model that can take the CT image, I mean the normal CT image, and they can convert it as the simulation image for the palliative radiotherapy patients in order to reduce the gap. So there is a available AI tools are there for the palliative patients, and I think that can be answered for the last questions. Whether is there any AI can do the simulation for the patient or not.
Okay.
So
Okay. No
I
further
think
I think
questions.
there
We can
is no
I
more
close.
think no
questions.
I think no more questions.
Yeah.
So yeah,
So,
it's really great with you.
So in that case, thank you, Professor Jin, once again for your time. I know you are really a busy guy, and we are really happy to have your insightful presentation today. And
Thank you.
thanks
It's
to our
really happy to be here.
moderator and of course all the participants for joining to the sessions. As you said, win-win. So let's continue working together to advance medical physics through the collaboration. Once again, happy IDMP 2025.
Yes. Happy IDMP 2025, everyone. Okay, bye-bye.
thank you. As we conclude today's program, I would like to express our sincere appreciation to Dr. Jin for sharing their experience and valuable insights, and also Dr. MD Akhtar Juman, President of BMPS, for his inspiring opening remarks. Our heartfelt thanks all go to the participants who joined us in celebrating IDMP 2025 and for your contributions and dedication to advancing medical physics. Thank you once again and wishing everyone a happy International Day of Medical Physics 2025.